Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, good afternoon. Thank you for joining us for today's webinar, Success and Growth with Skilled Nursing Management and Evaluation. My name is Laura Barnett, and I'm on the marketing team at Axxess. Axxess is a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Today, you'll hear from Arlene Maxim and Andrew Awaniyi. Arlene Maxim is a senior clinical consultant at Axxess. With decades of nursing experience, she previously co-founded regional multi-million-dollar Medicare certified home health care companies, hospital-based home care and hospice companies, as well as transitional care programs. Her working career has included direct patient care, progressing to clinical management oversight, executive level operations in hospitals and post-acute care settings, risk management in multiple healthcare settings, transitional care management, as well as providing strategy for organic growth and acquisitions across post-acute settings. Dr. Andrew Awaniyi is the Director of Patient Engagement at Axxess. He's worked across the continuum of care with interdisciplinary teams to improve clinical, financial, and operational outcomes utilizing process improvement and information technology. He leads the patient engagement team at Axxess, working with professionals across the U.S. on improving their engagement with patients through the CAP surveys and other tools and processes. A couple of housekeeping items for the day. We will be providing one continuing education credit for this webinar. All registered attendees who would like to receive this credit must be present for at least 45 minutes of today's webinar and complete the post-webinar training evaluation. Certificates will be emailed to the individual emails that registered for the webinar. You've been muted, but you may submit questions through the chat function in the webinar. We will follow up with you after today's webinar to respond to those questions. Slides from today's presentation, along with a recording of the webinar, will be available after today's session and will be sent to everyone who registered via email. They will also be posted on axxess.com. I know you guys have a lot to get to today, so Arlene and Dr. Andrew, take it away.
Good afternoon, everyone. Thank you so much, Laura, for that warm welcome. And we want to welcome everyone again, and thank you for spending your lunch hour with us. Arlene and myself and the Axxess team are truly excited to bring you this topic of success and growth with skilled nursing management and evaluation. And just a quick reminder regarding the certificate of completion. Our goal during this hour is to attempt to do justice to this particular topic, but we know that an hour is not enough. So we have a very ambitious goal, which is really just to touch on chronic diseases and their impact on the healthcare system and the role that we play as home care organizations. Opportunities for really using skilled nursing management and evaluation for home-based chronic disease management programs. And then really talking about some of the tools and processes that will help build a self-sustaining chronic disease management using skilled nursing management and evaluation, and then just touch briefly on some future trends. We would love to get to know you a little bit better since we're working through a virtual environment. And so you'll see a poll up on your screen, and we're just interested in having an idea of how familiar you are with management and evaluation of the care plan. And if you would just take a few seconds to complete the poll on your screen of choice, since we know a number of different people are accessing it from different resources. And we will close the poll here in the next 5 seconds if you've not gotten a chance. And let's go ahead and take a look at the results. All right, so we can see that the majority of attendees are somewhat familiar, meaning that they occasionally utilize skilled management and evaluation. And a good number, at least a quarter of us, routinely utilize it. And we do have a small number that are true experts. So thank you so much for participating in the poll and giving us a sense for the level of knowledge of all our participants. So we'll proceed by just touching on a few numbers. When we think about the work that we're doing as in-home care organizations, we know that the majority of our population are older adults, adults over the age of 65, and this is just another reminder of the fact that an estimated 15% of the population really is considered to be an older adult. And thanks to the baby boomers, some would call them the golden generation because everything they touch turned to gold, are starting to turn silver. And so we can see that projected out by the year 2060, almost a quarter of the estimated population of the United States will be older adults. Conversely, we see that children under the age of 18 currently comprise about 23% of the population, and that number will decline slightly to about 20% of the population. The magic year, obviously, all projections will be 2034, where there'll be that crossover. So what we can take from this is the fact that the United States continues to age. No surprise there. But as we can see, that crossover point is coming fairly quickly. So what comes with that? We know that older adults also tend to have chronic diseases, and heart disease, cancer, stroke, and as we can see from this chart from 2003, really lead some of the major chronic diseases and have a financial impact. Back in 2003, the direct cost for treating chronic diseases essentially were a little over $250 billion. The total economic or estimated total economic cost for treating chronic diseases were about $1 trillion. Fast forward to the year 2016, and we can see that our current direct costs are about $1.1 trillion, and total costs are about 3.7 or almost $4 trillion. When we look at some of the key chronic diseases, we still see that cardiovascular conditions, arthritis and back pain, diabetes are in the top 3. And we know that all of these are impacted in some instances by diabetes, by obesity. And so we know that in looking at this escalating cost, that over time, it's simply not sustainable. And so chronic disease management features very heavily into this projected cost. And as we can see from this graph, looking out, and this is obviously the per capita spending for healthcare only continues to escalate. So in summary, when we really think about the state of affairs when it comes to chronic disease, it's increasing costs, increasing number of people with chronic diseases, including nurses, and the fact that the highest cost of care is the 10% of the population that does have serious chronic diseases. And we know that 1 in 4 adults have 2 or more chronic health conditions that lead to much higher costs. So our discussion today really is focused around a methodology, which is the skilled nursing management and evaluation as one of those skill sets for really tackling the issue of chronic disease. And as you can see, we love polls. And so here is another quick poll where we just wanted to get a sense for how often your organization has used skilled nursing management and evaluation within the last year. And this is from a percentage perspective. So we know these are rough numbers, but we'd love to hear what percentage of you continue to use skilled nursing management and evaluation. Okay. And we'll give you about 5 more seconds to provide us your response. And let's take a quick look at the results. So we see that about 18% are very successfully using skilled nursing management and evaluation. If we were in a room, we'd love to hear about your experience. But since we're virtual, we look forward to hearing from you. Roughly the same number are using it at least half the time, and then about a quarter of us are using it about half of us are also using it up to a quarter of the time, anywhere from 0 to 25%. So thank you again for sharing this, and I'll turn it over to Arlene to speak some more about management and evaluation of the care plan.
Well, thank you so much, Dr. Andrew. Those are some interesting numbers. When I've taught this in the past, I haven't had such high numbers in that for people actually using it. So hopefully by the end of this session, you're going to have a better idea of how to do documentation. Many agencies tell me that they don't want to use management and eval because they're going to get denials. That's not so. There was a time in our home care past that there were denials going out for management and eval, but that's been long gone. And as long as the documentation is done correctly, we should be as good as we are with any of the other records. So, and to begin with, for me, I'd like to talk to you about the, can you go back one slide, Dr. Andrew, please? Okay. This, to me, the management and evaluation of a care plan is kind of like a bridge. If you think about the patient having acute care coming home from the hospital and you're resolving all the skilled issues, then putting them on management and evaluation for a time so that when they come to an acute episode once again, you're not going to have to do another face-to-face, another complete plan of care, that kind of thing. So just keep that bridge idea in your head. So this is something that is a skill, and we're going to talk about that, but it's actually a bridge between 2 acute episodes from the hospital and then possibly them going back into the hospital and then you taking them on again or something changing during that period. Okay, next slide, please. So these are the items. If you haven't looked at Chapter 7 for a while, you might want to take a look at it. These are the things that Medicare actually pays for. And management and evaluation, by the way, is a Medicare program. It's not seen in Medicaid. It's not seen in, as far as I know, in any of the insurance policies. But these are the covered services. So many years ago, a little bit of trivia for you. Many years ago, back in 1989, observation, assessment, and management evaluation was one skill. There was an incident with, it was HICVA at the time, where there were some lawsuits going on, like kind of we see now, and the management evaluation of a care plan was actually identified by the National Association of Home Care, and they said these are 2 entirely separate skills. And so the government decided to separate those two skills. And so management and evaluation of a care plan stands all by itself. We see teaching and training. Of course, teaching and training activities is most of what we do, probably 85% of what we do. Administration of meds, tube feedings, all of these other skills. And it's interesting for you to go back and take a look at it and make sure that every time you document in your clinical record, you're documenting one of these skills. So as far as skill management evaluation goes, it is a covered skill. And so that's something I think folks have to wrap their head around. So that although a properly instructed person can perform the required services, that person would not have the capability of understanding the relationship between the services that affect each other. So for skilled nursing, we have to make sure that whatever we're providing is something unique to our skill. I have a good friend, when she does seminars on maintenance therapy, she talks about the magic of me. What is the magic of the registered nurse? What does a registered nurse know that the common, the lay person does not understand, and would not understand that there was a problem going on with the patient? So that's one of the things that you need to think about when you think about whether, no matter what it is, whether it's skilled management evaluation, teaching, or whatever, is it covered? Is it something that takes the magic of you, the registered nurse, to perform? Since a combination of patient's age, condition, immobility create a high potential for serious complications, the management of a care plan is covered services. So what we're doing with this is isolating the unskilled care plan and looking at the patient and determining whether they have something going on. A head-to-toe assessment, of course, you're always going to do when you go into a patient's home, but you're looking at the care plan that you have designed as a registered nurse for the patient and determining whether or not the care plan is working, or if it isn't, if it needs to be changed a bit. And so that's the whole intent of management and evaluation of the unskilled care plan. So to be covered, and this is directly out of Chapter 7, to be covered as skilled nursing services, the skilled services must require the skills of a registered nurse or licensed practical nurse or vocational nurse under the supervision of a registered nurse. The skill must be reasonable and necessary to the treatment, illness, or injury as discussed in 40.1.1, and must be intermittent as discussed in 40.1.3. Keep in mind that the intermittent service is only identified in skilled nursing. It's not included in the therapy, social worker, or any of the other disciplines. Coverage of skilled nursing service is not turned on the presence of an absence of patient's potential for improvement or the nursing care, but rather on the patient's skilled needs. So it's important that when you're doing your OASIS assessment or your integrated assessment, that you need to identify that why the patient needs particular services that you're providing. Next slide, please. Thank you. In another portion of that chapter, they tell us that skilled nursing services for management and evaluation of a care plan is reasonable and necessary where underlying conditions or complications require that only a registered nurse can ensure that the essential non-skilled service is achieving its purpose. So that's what I was talking about when I said whenever you go in to see the patient, you're going to do a head-to-toe assessment, find out if anything's changed. If something changes, then you might want to put the patient back on routine home care. But this is a skill all by itself, so all you're going to be doing is making sure that that unskilled care plan is appropriate, that it's being followed, that there aren't any changes that need to be made. The complexity of the necessary unskilled services that are necessary part of the medical treatment and must require the involvement of skilled nursing personnel to promote the patient's recovery and medical safety in view of the patient's overall condition. So we want to make sure that we continue to work on the patient's recovery and that the patient is safe. So that's some of the key things you're going to want to look at. So when you're doing your documentation, and this is where I find that nurses often have a struggle, that when you're doing your documentation, all of your documentation needs to relate to the unskilled services in the care plan, and whether or not that home health aide or the aide or the family members are actually following the plan as you've designed it, or if there needs to be alterations made in that plan. Next slide, please. So in 2012, this was interesting, and this is another thing. If you don't know about it, you want to go back and take a look. There was a CMS settled a case with Jimmo, and it was called a Jimmo versus Sibelius case, and it was a Mrs. Jimmo that had been denied services because she did not have a chance for improvement. And if you look through the Medicare manual and you have nothing else to do, if you want to look at Chapter 7 and read it, you'll find that there is nothing in the Medicare standards, the Medicare policy, that indicate a patient has to improve. So Sibelius happened to be the director of HHS at the time, back in 2012. And so there was that settlement that came up. And so Medicare now agrees that services are going to be paid if they're needed to maintain the patient's current condition or prevent slow deterioration. You do not have to show improvement. So if we want to maintain that patient's stability with their condition. So the two things that this has really highlighted in the Medicare coverage is management and evaluation of a care plan for nurses, and then maintenance therapy for physical therapy, occupational therapy, and speech therapy. Now and we're not going to talk about maintenance therapy today, but during this pandemic, one of the waivers allows for PTAs, OTAs, and STAs to actually provide maintenance. But that's not so for the management and evaluation of care plan. There was no indication that LPNs or LVNs would be able to actually perform this service. It must be an RN. So the goals here is to reduce hospital admission and readmission rates. So this is one of the most exciting things to me, and this is what I mentioned about the bridge, where we talk about the acute care episode, the bridge between two acute care episodes. So we can actually, I believe, reduce hospitalizations by having a strong management and evaluation program. And once that patient is discharged, you need to ask yourself, would I be surprised if this patient went back into the hospital over the next few weeks? If your answer to that is yes, then you would definitely want to put them on management and eval. Make sure they have an unskilled caregiver available. You can use home health aid for that, but you have to have an unskilled caregiver to have this service provided for management and eval. Allow patients to age in place at home. Typically, I've read some statistics about management and eval, and they say that about most of the patients are over the age of 85 years old for this service. That doesn't mean that no one else can have it, but it just seems that typically we find patients over the age of 85 that are placed in management and eval. They provide care for IAH and ACO patients using home care as a home health as a partner. This absolutely reduces their outlay of money. If we can keep the patient home, these types of programs are not going to have to spend the money that they normally would if you're not watching over that patient. Develop strategies for skilled cases to manage chronic care using management and evaluation as a skill, as the CMS skill for home health. So you want to look at some of these chronic care patients, particularly those like with MS, Parkinson's, those types of patients where you get them to a stage that they're stabilized as far as nursing is concerned, but they still may need something more and something may change during a 30-day or 60-day period. So you want to make sure that you're going in there every couple of weeks to take a look at them. Next slide, please. Thank you. So the key coverage concepts are we want to look for underlying conditions or complications. And of course, most of the patients we see have multiple comorbidities. I believe that Dr. Andrew mentioned that on one of the graphs that he was looking at. Non-skilled care must be provided by someone in the home. For provider services, we can use provider services, the unskilled care, home health aides, or family caregivers. CMS would like to see something other than home health aides. It's not that you can't use home health aides as the unskilled service service, but they would like to see like family members or their paid caregivers being used. The RN, as I mentioned before, has to manage a case. LPNs and LVNs are not covered under the skill. In fact, you'll see in the G codes that you use for billing, there isn't even a G code for this for LPNs or LVNs. As a caregiver, has the caregiver lived in the home or assisted frequently outside the home? So the patient has to be homebound. So those are the two qualifiers that you have to think about when you're deciding on management and evaluation. One is, are they homebound? Of course, all of these patients that are receiving Medicare funds have to be homebound. And then the second thing is, do they have the unskilled caregiver in the home? The physician has to document the need for management and eval. We're going to look at those items that they have to, the physician needs to actually document. And of course, the physician rarely takes the time to document what we need. So we have to put the documentation in there and show them where to sign, and the physician, he or she, needs to agree with that. Next slide, please. So there are 4 referral triggers for skilled management and evaluation. So things for you to watch for, even at intake. There are times I believe that at intake, and of course with PDGM, I think that intake needs to take a much more active role in what we do overall in home care. But there's some triggers that we can look for to say, hey, watch out for this patient because they might be eligible for skilled management and evaluation at some point during the episode, perhaps at the 30-day period or perhaps at the end of the 30-day period. So the patients are at high risk for hospitalization or exacerbation of their health problem. The patient has a complex non-skilled care plan, of course. There's an unskilled caregiving situation going on, as we mentioned, and the skills of a registered nurse is needed in order to coordinate and manage the patient care. Now, one of the things I wanted to make sure you understood too is that during the time the patient is on management and evaluation, the patient can also receive physical therapy, speech therapy, occupational therapy. It doesn't have to be maintenance. They can be on a regular therapy program during this time. So keep that in mind. So one of the triggers is if the patient's is the patient at high risk for hospitalization or exacerbation of a health problem if the plan is not implemented properly. So we need to document that very carefully. We need to make sure we have that in our documentation, that they are at high risk for hospitalization. We need to make sure that we have that in our on our plan of care. So the patient typically will have multiple diagnoses, many comorbidities, functional and mental limitations. Even patients with Alzheimer's would be indicated for a management and evaluation program over a period of time. A history of hospitalizations from improper, inadequate care. And that's true that improper and inadequate care could be part of it, but just the fact that they have a history of hospitalizations or emergency room visits could be an indicator for management and eval. And then if you have safety concerns about the patient, if the patient wanders, if the patient has frequent falls, those are some indicators for management and evaluation. So Dr. Andrew, I will turn this over to you to talk about the second trigger.
Sure. With trigger 2, as mentioned by Arlene, does the patient have a complex non-skilled care plan? As we discussed a few minutes ago, the requirement is that the coordination of care by unskilled providers requires the skill of a registered nurse. And so when we think about the polypharmacy that can come from multiple medications and just the complexity of treatment along with all the medications, and when we add in equipment and supplies, can the unskilled care providers truly manage all that complexity? And when we as skilled providers take a look at all that, that should be a trigger for the fact that maybe this patient does need skilled management and evaluation. And then while we're on the topic of the caregiver, really thinking about who is really caring for this patient. Are they a private caregiver? What sort of expertise do they have? Are they someone that walked off the street and hasn't had any type of training? Is there a lot of turnover? Are there multiple caregivers that are coming in? Do they truly understand how to care for this patient effectively, and what's their history? And because we're talking of on-scale care providers here, there's a need for us to really evaluate the situation and really monitor. And some of that will be evident if we're familiar with this patient's care. But our goal really is to ensure that the patient continues to remain safe. And I'll turn it back to Arlene for the fourth trigger.
Great, thank you. So the fourth thing we want to look at, there has to be an RN. So does the RN have to be involved in the patient's care to implement the plan? And again, does the registered nurse have to be in there to oversee the care plan? So if the patient has falls, you're going to want to put fall assessment on there. You want to make sure that the unskilled caregiver is following a fall protocol, and maybe working with the therapist that you have some fall precautions put in there. It has so the RN, of course, as we mentioned before, has to be in there in all cases. And then again, you want to make sure that you are doing a head-to-toe assessment. I can't stress that enough. Looking for changes, because if something changes, this is probably not, so like if they have identified multiple new medications, if they've gone to the doctor's office, if they've gone to the emergency room while you were there last, you might want to put them on routine skilled services. Next slide, please. So ask yourself, what is the skill of the RN? Of course, the skill of the RN is going to be the oversight of the unskilled. Are there non-skilled care? Is there non-skilled care in the home for the RN to manage? That has to be in place, and you have to identify that on your plan of care. How will the patient's needs be met if discharged from home care? What will, and of course, that's part of our discharge planning anyway. So we're going to be able to identify that. That would be kind of an interesting thing to put on your assessment tool that you're using, and do that every time you start to discharge a patient. Would this patient qualify for management and eval? And who's going to perform the care? You don't have to identify the actual person's name, but you have to identify who that person is going to be on the plan of care. Is a patient likely to end up back in the hospital? Again, this is one of those trigger points. It's probably one of the biggest ones that you're going to find, and this is one of the things we want to avoid, is that rehospitalization, particularly now with this pandemic. These patients do not want to go back in the hospitals, so for us, protecting them in the safety of their own home is really, really important to them. Dr. Andrew?
Thank you, Arlene. And so we thought it would be helpful to provide a case, and I think you might have read the case in your handouts, but the cogent points are: this is a 78-year-old patient with a mild history of dementia, Alzheimer's in this case. They're recovering from pneumonia, which has been treated in the home. However, they seem to have some residuals, such as an increase in disorientation. They've been confined to their bed and to the home, and so it's understandable that they probably have a decreased appetite and maybe some residual chest congestion. So if we think about the 4 triggers, here are some questions that we might want to consider in evaluating whether this patient is appropriate for skill management and evaluation. And as mentioned with Arlene, we want to ensure that we've adequately assessed them. We have a fairly good handle on the care that they've received up until this point in time, either through a review of their discharge instructions and any documentation we can find about their care prior to being admitted. But if we look at their residual chest congestion and recovery from pneumonia, if that were solely what we were looking at, we might not consider them for skill management and evaluation. However, we see that as a consequence of their pneumonia, they are having some immobility and confusion issues and a little bit of appetite. So are they a high risk for hospitalization, or is there the possibility of an exacerbation of their dementia as a result of their pneumonia? What kind of care plan will they have in order to manage their condition? And are there any underlying conditions that might play into their risk for hospitalization? And then obviously looking at their caregiver situation, do they have a caregiver? If they do, how familiar is the caregiver with the care that they've received? And again, the utmost question, which is, can the skills of a registered nurse assist with coordinating and managing that patient's care? We've included just a rough mock-up looking at the fact that they would most likely be late community with comorbidities and maybe a low functional score. To the right, you can see that the LUPA threshold, since their category, their PDGM category would be the neuro rehab. This obviously is a case study, just a real simple example. This might be how we would schedule them out. And the key thing to notice is the fact that we've worked on scheduling the home health aide and the skilled nurse visits to be interspersed with a Tele-Touch, which is a term we like to use, where we're following up, providing supervision of that unskilled care provider, reviewing the care that they're providing. If we are fortunate enough to have access to remote patient monitoring, being able to use those capabilities to really see what's going on and oversee the care that the patient is providing. And just putting together some real simple numbers. Obviously, it'll vary from organization to organization and your location, but in this scenario, we're projecting roughly a 25% gross margin from care. And if you think about the possibility of using a caregiver that maybe the patient's family has hired, those margins would go up. So not exactly margins that would be as high as some other cases, but enough to make it worthwhile to really care for this patient.
And just to add to that a little bit, sometimes with these patients on management evaluation, it's not so much the amount of money you make. You might lose money on some of these cases, but again, it's that bridge that you need to think about. You're keeping them out of the hospital, you're maintaining that relationship with that patient. Referrals are really difficult to get right now, so you need to think about that. So we wanted to talk about what management evaluation is not, and we talked a little bit about this, that it takes the skills of a registered nurse, and what is that? That's the management evaluation. What it is not, it's not just an excuse to fill a med planner. And I know a lot of agencies think that filling a med planner is a skill and it takes the skills of a registered nurse to do it. It does not. Medicare does not see it that way. So if your documentation is such that it indicates that the primary reason you are in there is to fill the medication planner, they will deny that claim. Now, it's not to say that you can't fill the med planner when you're in there, but that should be one of the things that you're overseeing, that you've taught the caregiver to fill the medication planner, and that should be one of the items that you're overseeing. It should not be a way to continue home health aides just when there is no other skill present. And that's another thing I find in reading documentation. Agencies will try to use management and eval because it's a skill to put home health aides in because a patient needs help. You need to get a social worker in there if that's the case before you do the discharge. Medicare is not going to pay for the home health aide. And that's the only reason you are using management evaluation is to oversee that aid. And that's why I mentioned earlier that CMS really wants to see caregivers that either the patient is paying for or family members in the home. And you can use a home health aide for a short time, but that would not be a routine thing that you would want to rely on. So it shouldn't be for long-term observation and assessment. And as I mentioned earlier, observation assessment used to be included with management and evaluation. They separated that for a reason. If you're observing and assessing a patient, then they don't need management and evaluation, vice versa. You will observe and assess for changes with the patient, always. You're always going to do a head-to-toe assessment with that patient, and you're going to look for changes, but that would be the only time. So that's not the reason. And if the documentation shows that as a reason and CMS can't see anything else, then you will not be paid. It can't be indefinite care for a non-compliant patient. Well, the most recent conditions of participation have given us a way to be relieved in non-compliant patients. So that shouldn't be something you want to be relying on either. You probably don't want to stay in there for a non-compliant patient. So, but anyway, so oversee, make sure that your documentation is specifically geared toward the oversight of that unskilled care plan. Next slide, please. Dr. Andrew?
So we decided to just throw in a second case just to take a look at where we have a fairly common scenario where a patient with a history of type 2 diabetes with angina happens to go in for a surgical procedure, an ortho procedure of open reduction of the neck of the femur. Obviously, there will be the need to very carefully manage their skin care. Being someone with type 2 diabetes, there's a high likelihood they probably have oral medications. The need for really monitoring their diet and their exercise to improve muscle tone, but also to help control their disease, and ongoing observation from any complications related to the restricted mobility that would have occurred with this surgery. And so just some questions to ask ourselves again, thinking about the 4 triggers. Obviously, we most likely would have managed this patient in order to post-surgery, in order to ensure that they would not be readmitted. But once we've provided the initial care, the question becomes, do they have any underlying conditions, or did they develop any complications or have any comorbidities that would determine, that would potentially have them readmitted? Because with a patient with that has diabetes, if their blood sugars are out of control, we know that they have a much higher chance for developing some sort of infection and having so many additional complications. And so the question is this case complex enough for them to be managed by management and evaluation? One conclusion could be it depends. In this scenario, we clearly might not have offered enough information to make a decision. We did just put together some numbers. Obviously, this patient is undergoing rehab for their surgery. So this could change depending on how the scenario played out. But again, we can see that there are a number of things that we can do, obviously, to arrange the care for scheduling the care for this patient and managing them overall. And as mentioned by Arlene, in this case, we happen to show a small margin here, but it could go in either direction.
Okay. So thank you, Dr. Andrew. That's really good information. I think people do get concerned about the cost of doing this sometimes, but we have to look long term and figure out, what are the advantages of this. So this is something that I think you need to really pay attention to. It says it's intake documentation, but this is exactly what needs to go on the patient's plan of care. So some of you might call the 45, but it's the patient's plan of care. And we have to have these statements on there, and the doctor has to agree to these statements. They're certifying the overall condition, and they can identify what the comorbidities will result in unplanned hospitalizations. Without skilled management and evaluation of a care plan by the RN, the safety of this patient cannot be assured. The underlying complexity of the patient's history and medical regimen. The patient has non-skilled caregivers who are unable to assess the patient for potential problems. All of these items have to be on your plan of care. The other thing, the physician, so your plan of care, you need to make sure that you've got a place on your plan of care where the physician signs directly under these statements. So if you look at the Medicare policy manual, it'll tell you they want to have this information, they want the physician to write it, and they want the physician to sign, date, and put the time that he actually signed it. It's really, really important that you have this on there. So next slide, Dr. Andrew. So some examples of documentation, the blood sugar. So in some of these unskilled care plans, you're going to have logs. You're going to have logs for blood sugars. You're going to have logs for, you might have logs for blood pressures, for temperatures, whatever. The blood sugar log reveals blood sugars ranging from 80 to 130. Contacted Meals on Wheels spoke to Juana Flores, who stated they were delivering a diabetic diet for lunch, spoke to the daughter. Mrs. Luke, who stated that she is providing no concentrated sweets. So this is a nice summary of a diabetic patient and what the nurse actually observed and what the nurse followed up on while she was in the home. So this is really good documentation for a management evaluation care plan. So we might want to put, again, identify that the skin conditions without signs and symptoms of breakdown. They performed the aid care, the aid care plan was modified to reflect the shaving of the patient, as the wife states she was experiencing fatigue and is afraid she'll cut him. The patient's wife was pleased with the care of the aide. That would be on your supervision notes. The wife states that she's performing strengthening exercises left by the therapist, and the aide also performs them on bath days. One thing that was not built on those schedules we gave you is don't forget you have to do aide supervision. If you have your own home health aide from your agency in there, you have to do that aide supervision every 14 days. So when you're mapping out your skilled nursing visits, you want to make sure that you get them at least every 14 days. If you do them earlier, that's fine, but at least get that every 14-day supervision in there. Some non-covered services, again, as I mentioned, your documentation is going to be the determining factor for whether these visits are covered or not. So some examples of non-covered cases would be a physician orders 1 skilled nursing visit every other week and 2 aid visits a week for bathing and washing the hair of a patient recovering from a CVA. The cardiovascular condition is stable and the patient has reached his maximum restoration potential. This is considered custodial care because someone, just bathing and washing of hair would not be necessarily the oversight of a complex patient. So you have to make sure that whatever you have designed in your care plan, you make sure that you show that it's a complex care plan. Documentation that would be worthy of payment would be a patient with a recent GI virus that caused nausea and vomiting and left the patient weak. Patient's cardiac condition is not stable with blood pressures that are slightly elevated. So you probably have some type of plan in here for looking for electrolyte disturbances and that kind of thing, so that your aide could let you know, or the unskilled caregiver could let you know with a GI virus that that patient is experiencing some electrolyte. As far as cardiac condition, if the blood pressure becomes elevated beyond parameters, they would be able to notify you of that. You would want to have a log for blood pressures in there, and you would want to show that you're actually looking at that and identifying any problems and the potential for need of changes in medication or treatment with that patient. So some tips that I have for you would be, so patients that you're looking at, and again, I think intake is a really good time to start that process. Consider looking at those chronic patients with multiple diagnoses, those comorbidities that that patient has. Is there non-skilled care in the home? Again, there has to be non-skilled care in the home, and that's another qualifier. The patient has to be homebound, and they have to have non-skilled care. Again, they can be home health aide, family members, or community services. Is the patient still at risk for readmission and complications due to the complexity and the availability of the non-skilled care? That needs to be documented not only in your assessment, but remember the doctor has to verify that that's true. And you can perform teaching under management and eval. Usually that would be reinforcement. It wouldn't necessarily be new teaching, because if teaching is required, if they have a new medication, if they have a new disease, if doctors change something, you're going to want to take them out of the management and eval of an unskilled care plan, put them back on regular skilled nursing, where teaching would be included in the documentation and in the payment that CMS would consider. And then I think the last slide that I'll be covering is the additional tips. And so CMS tells us that generally you're not going to see management and eval usually a couple times a month. It can be less frequent. It could be once a month, depending on the degree of complexity of the case, but generally it's not performed more than twice a month. So you may keep patients on this program for several certifications if the underlying conditions require the nurse to handle the case. I would look at that very carefully. This would be something that I would consider on recertification, taking to one of your case managers and deciding whether or not it goes on. So a couple certifications probably is extent that CMS would consider. If the patient's stable after a couple certifications, you might want to consider discharging. Management and evaluation can be a standalone service. It can be blended with other services such as therapy. I would be careful, just as I mentioned with the item above, I would be careful with teaching and observation assessment and identifying that as a reason being in there, because that's more of the other skill, the routine nursing skill. And it's not that it can't be done. And observation assessment, of course, I said you're going to do that every time, but that's not the skill that you're looking at when you're doing management and evaluation. The skill is the oversight of the unskilled care plan. And then therapy. Some agencies I've talked to get confused, and they think that if therapy is still in there providing their skill, not maintenance, but providing skill, that skilled nursing couldn't put the patient on management evaluation, and that's simply not true. The management and evaluation is just skilled nursing by itself, so all the other disciplines can be provided. And again, it is a skill. So as long as you can understand that and get that straight in your head and in your documentation, you'll be able to see that all the other disciplines can go in there. So you could have social worker in there, and that might very well be appropriate for some of these cases. Most cases are going to start with observation and teaching, and that's true. Like I said earlier, teaching is probably 80% of what we do in home care, and then observation assessment. But observation assessment all by itself can only be in there for 3 weeks unless you have documented some possibilities of exacerbation. So those are the tips I have, Dr. Andrews. You would like to summarize the session, please?
Well, thank you so much, Arlene. I think those tips are extremely valuable. I think both for someone who might be seasoned and brushing up, and someone who's contemplating really getting into it. As we move towards the end of our hour together, we just wanted to touch real briefly on really the Tele-Touch. We had alluded to that earlier as a way, especially with the Medicare waivers around the use of telehealth. Unfortunately, we have not gotten to the level of reimbursement. However, we've made progress, and CMS has recognized the ability to at least use telehealth and include it on the cost report. So we know that clearly for chronic disease management, skill management and evaluation is another tool in our toolbox for really helping bend the cost curve and really showing the value of in-home care in really addressing the challenge of escalating costs due to chronic disease. And using telehealth will help further. And we'll leave it to our advocacy organizations to rally us to work towards getting reimbursed. But between now and then, we know that going into these various patient encounters with purpose and really with being goal-oriented is extremely important. And so if you're not using a telehealth solution, and when we talk about telehealth and Tele-Touch, it's essentially using whatever technology is required. So using the broader umbrella term for telehealth to really work on leveraging it to manage those on-skill providers, providing the necessary guidance, and really doing case management or care management for those patients. And so these are some of the various ways in which Tele-Touch can, or telehealth technology can be used, everything from capturing vital signs to being able to do video assessments and capturing other physiological parameters for the patients, being able to do risk assessments in terms of really monitoring health indicators. And then as we've seen, especially with COVID, really accelerating the adoption of being able to use video to really watch patients perform either return demos or even doing teaching or training. And since we're talking about managing the care for unskilled care providers, even being able to monitor the care that they're providing via video. And so we know that the future of healthcare is in the home. That's something that we deeply believe in, and I'm sure we've all seen happen more so since the beginning of the year with the pandemic. And I think part of what we'll continue to see is various ways of integrating additional technology into truly managing the chronic disease management programs and really seeing more innovative ways in which they'll be incorporated. We wanted to, we didn't want to leave without at least getting a sense for, in our hour, whether we've moved the needle any by having our last poll to really gauge the number of you who think that there's an increased likelihood whether you will implement a skilled nursing management program, having learned more about it. I think Arlene would agree that when we were putting together the presentation, we didn't anticipate that there would be such a high level of adoption at the very beginning. So where do you think we'll land at the end of this poll, Arlene, with the number of people who may?
Well, I'm hoping 51 to 75%.
Okay. All right. If you haven't, if you've not cast your poll, we'd love to see that. And I'm going to go ahead and close the poll here in 5 seconds. And Arlene, let's see where we're at.
Oh, wow. Better than I thought. Good.
So, very encouraging to see that at least now that we've gone over, and we know it's really at a fairly high level, and stay tuned for more. We think this is an area that that a lot more in-home care organizations can benefit from, and knowing that it's reimbursable. So thank you very much for completing that poll. And just the key takeaways. Arlene, would you like to summarize?
Sure. With the increase in challenges of chronic diseases in the elderly, there's tremendous opportunities for us to take place. Dr. Andrew showed you some pretty shocking graphs at what we have coming up in the near future. And so we're going to have to look at some more creative ways to actually care for our patients and stay in business ourselves. Management evaluation, again, is an excellent but underutilized skill to use with chronic patients. I was talking to somebody from one of the MACs within the past couple of years, and they actually said to me, I don't know why that's not used more. We hardly ever see it. And I think it's because people didn't understand all by itself it's a skill. Number two, it's reimbursable, but also understand the documentation requirements. So perhaps Dr. Andrew and I can get our heads together and put together something much more specific about documentation of this program in the future. It can be combined with therapy maintenance program or other therapy programs. Like I said earlier, you don't be afraid of that. It's as long as you're doing the registered nursing skill of management and eval, they can have all the other services that CMS provides. Management and evaluation of a care plan reduces patients' chances of repeat hospitalizations. And again, at least during this pandemic, people do not want to go back in the hospital. The chances of them getting an infection in the hospital are extremely high. Health organizations are a perfect position to serve as a credible partner for managing these types of conditions. So in doing that, again, start an intake, retrain your intake, and add this to some of the things that they do in the intake program. Start looking at your patient ahead of time and planning for, as you plan for discharge. And of course, we have to plan for discharge from the beginning. So I think that this is the end of our presentation, and we certainly thank you for hanging in with us this past hour during your lunch. And hopefully you've learned something from this, and we'll have an opportunity to work with you in the future. Thank you.
All right, thank you so much, Dr. Andrew, and thank you, Arlene. We appreciate your time and sharing your wisdom with us today. Please remember, we will email everyone a link to the slides, and we're also going to post a video recording of the webinar on our website at axxess.com. You'll also get that via email. And you will additionally receive a post-webinar training evaluation. You have to complete that in order to get your CEU certificate. Thank you so much for joining us today as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Have a fantastic day.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.